जी मैडम, Assalamualaikum. Very good morning to you all. Myself, Lieutenant Colonel Jannatul Firdaus, welcome you all to this clinical session. It's a great pleasure for me to be a speaker of this class. Heartfelt thanks to Professor Brigadier General Nunar Fatima Madam. Now here we go with the cardiovascular system examinations. The component of the cardiovascular system examinations started with the peripheral manifestations of the cardiovascular diseases with vital signs like the arterial pulses, blood pressure, jugular venous pulse, and then precordium examination. Examination of the cardiovascular system first started with the washing of your hand. So I will share a video clip of the cardiovascular system examination. How will you start? First, wash your hand properly, then introduce yourself, then confirm the patient's details and take the written consent and explain the examinations. Then the patient should be exposed adequately above the waist and lying the supine position. First, look the general signs of cardiovascular system from the end of the hip bed side, the shortness of breath, central cyanosis, pallor, and edema. And then have a look for the cutaneous manifestations of the hands, like the peripheral cyanosis, sphincter hemorrhage, and genuine lesion, oscular nodes, xanthomata, and finger clubbing and do the Shamrose window test. Then assess and compare the temperature of the both hands. And lastly, examine the capillary refill time. It is better to check the oxygen saturation by using a pulse oximeter. Some renowned professor like our Professor Brigadier General Fatima Madam also like it. Before going to vital signs, vital parameters of the cardiovascular system examinations, I will want to discuss some peripheral. I will want to show the few slides of peripheral manifestation of cardiovascular diseases like cyanosis, clubbing, edema, and face and hand manifestation of cardiovascular diseases. Cyanosis. It is the blue discoloration of the skin and mucous membrane due to increased deoxygenated hemoglobin more than 5 gram per dl. Cyanosis are two types, central and peripheral cyanosis. This is the central cyanosis picture of, and this is the peripheral cyanosis. This is a video clip or animation video of a cyanosis. This is the site of the central cyanosis, skin and mucous membrane, and this is the site of peripheral cyanosis, fingernail bed. Central cyanosis is due to decreased the arterial oxygen saturation due to circulatory or ventilatory or respiratory causes, and the peripheral cyanosis occurs due to the peripheral cutaneous vasoconstriction due to severe cold exposure. Another terminology is differential cyanosis, which found in the PD with pulmonary hypertension. Cyanosis seen in the lower limb, and in case of transposition of great arteries, cyanosis seen in the upper limb. This is the picture showing the upper limb cyanosis absent and lower limb shows the cyanosis. Finger clubbing is the bulbous enlargement of the distal portion of the disease, and which first stage is the loss of the fingernail. Normal fingernail bed angle between the nail and nail bed is 160 degree, and clubbed finger, in case of clubbed finger, it is the 180 degree. This is the normal window test, Shamrose window test, positive in case of the normal finger and lost in clubbed nail. The angle between the nail and nail bed is 160 degree. This is the called Loewe-Bond angles. First appears in index finger, and grading of the clubbing is the first obliteration of the angle between the nail and nail bed, then positive fluctuation test, then appears the parrot bead appearance, and then drumstick appearance, and lastly hypertrophic osteoarthropathy. This is another video clip of the clubbing examination. First, inspect from the side of the nail bed. Examine the fingers from the side, then do the fluctuation test. Is it positive or not? In case of clubbing, fluctuation test is positive. Then do the Shamrose window test. This is the window test. Window test positive in case of normal finger and lost in club nail. Edema is a clinical condition characterized by accumulation of excess interstitial fluid and can either be localized or generalized. In the blood vessel, blood flow and blood is maintained by the hydrostatic pressure and plasma oncotic pressure. In case of increased hydrostatic pressure and decreased colloidal osmotic pressure, fluid shifted the interstitial fluid and causes the edema. Edema also caused by increased capillary leakage and obstruction of the lymphatic flow. This is the common site of edema. This is the examination site. This is the medial malleolus, above the medial malleolus and above the sheen of the tibia. Now I request Professor Brigadier Nunar Fatima Madam to say a few words regarding this cutaneous manifestation of some cardiovascular diseases.
Thank you, Jandan, for nicely showing the first few segments of the examination of the cardiovascular system. For the student, I just want to tell you some key points. So first important thing is to look. So first thing, before starting your proper examination, you have to look at the patient. So first thing is look, second thing is feel, and third thing is auscultate. So look, feel, and auscultate. These are the three parts of examination of not only cardiovascular system, it is the part of any of the system. So Jannat was actually telling the look part mainly, and I also love to see whether student is looking properly to his patient. So in the look part, what will you do? You will first see, before that you have to introduce yourself, you have to take your hand wash, and then you have to warm your hand, then you have to handshake with the patient, and by your handshake you will get some very good information. For example, by handshaking you can understand what is the temperature of the hand. So this is a greeting. You are doing your greeting with the patient, you are introducing yourself with the patient, and then you are also doing handshake, which is a part of examination. In your handshake, you will understand whether the patient's hand is warm or cold. So if it is a cold, then it is a poor perfusion or maybe some of the disease. If it is like sometime there is sweating in the hand, so that is also a part of some of the disease like thyrotoxicosis. So you can understand by shaking your hand, and even sometimes the patient, they become like afraid of examination. As we are concerned with the children, so children, they are worried. So sometimes they start shivering. So you will understand whether they are afraid or not by shaking your hand also. So firstly, you introduce, you take preparation, you wash your hand, you handshake, and then you look at the patient and the surrounding of the patient. It is very important for you to see the surrounding, whether the patient is attached to the oxygen supply, whether there is any IV line, whether the patient is getting any IV fluid, or whether any cannula is connected to the patient, or whether there is any ventilator or anything, any support, or whether the patient is in cardiac monitor. So or whether there is any urinary catheter or any other aid like peritoneal dialysis, or like if it is in ICU, you can see some chest drain. So you look for all these things first, that what are the other things connected with the patient. And then you see whether patient is lying in supine position or in a propped up position or in a sitting position. So whether the patient is comfortable, whether the patient is dyspneic, whether the patient is cyanosis. So by looking towards the surrounding of the patient and the patient face, you will understand many things. If a patient is good, then he will not need any support from his surroundings, and patient will lie comfortably in the bed, and there will be no dyspnea or nothing. So this is a kind of normal patient, and you can proceed with the examination. But if you see that patient is dyspneic, patient is having some problem, So you have to take some extra care so that patient will not be more distressed by your examination. And then after that, you have to classify, first of all, the examination. As I said, look, feel, and auscultate. Other than this, you have to classify in some other ways. Like, first of all, we can, from the look part, we can see the hand and face. Hand and face are the main important thing of getting peripheral sign of the cardiovascular disease, which Jannat has already finished. And this look part is the hand and face examination is very important. And then you have to examine. So if you go chronologically, then next part will be the examination of the arterial system. We know that cardiovascular system consists of artery, vein, and heart itself. So arterial system you have to examine by examining the pulse and the blood pressure, and like you have to palpate all the great vessels which are palpable. Venous system you have to palpate jugular vein, and you have to see all the peripheral veins. When it will come, I will discuss. And then the precordium is one of the important, and then you have to examine the chest and also the abdomen. So in the superficial part of the examination, by seeing the face, you can identify many syndrome which are very, very common with us. So if you see a Down syndrome, you will understand that there may be some association with the cardiac disease. You can see Noonan syndrome. You can see like rubella syndrome. You know, we have identified a new faces called rubella faces. And we will surely ask this question in examination about the rubella, because this is a new identification from our country. So you all should know that. And then from the face, you can see cyanosis, and then xanthoma, xanthelasma, and Jannat did not mention in her slides. Xanthelasma, you know, this is the yellow deposition in the eyelid, especially mainly in the upper eyelid. And it is like xanthoma, these are common with the hypercholesterolemia or like lipid disorder. So this kind of thing you can, other than cyanosis, you can see xanthelasma also. And also like you can see some deformity in the face, which are associated with the cardiac disease like cleft lip palate and some other abnormalities, even deformity in the ear. These are also associated with the cardiac disease. And in the hand, other than cyanosis clubbing, you can see like some smoker in the adult patient. You can see the stain of that in the finger. And in the eye, you can see some arcus, which is a part of the hypercholesterolemia. So xanthelasma, arcus, then xanthoma. These are also the manifestation of the familial hypercholesterolemia in case of children. But in adult cases, it may be due to some other cause. So these are all about the peripheral part before going to the proper examination. And I will be very happy if you keep a pulse oximeter in your pocket so that you can measure the oxygen saturation also. Because you know, if reduced hemoglobin is not more than 5 gram, or if saturation is not less than 80%, you will not be able to identify cyanosis. So if you have a machine, it is very cheap now, so you can easily identify the cyanosis. Okay, Jannat, you can proceed now.
Yes, madam. These are some peripheral cutaneous manifestation of some pictures of cardiovascular disease. These are clapped nail. This is the colonychia. This is the palmar erythema. This is the genuine lesion. This is the oscular nodes. This is the sphincter hemorrhage. This is the picture of sphincter hemorrhage.
Come back to previous picture, previous slide, and you just tell them. If not, you just tell them what are the disease associated with this condition.
Madam, primary erythema. Okay, primary erythema, sphincter hemorrhage, genuine lesion, oscular nodes, all are the clinical manifestation of infective endocarditis. And colonychia you can find in iron deficiency anemia, and the clubbing found in many congenital cyanotic heart disease, also chronic obstructive lung disease. And sphincter hemorrhage and genuine lesion and oscular node also found in the infective endocarditis patient. Now a pulse is a waveform that is produced during the cardiac cycle, which travels along with the arterial tree. These are the different sides of the pulse. This is the carotid pulse, the brachial side of the brachial pulse, radial side of the radial pulse. This is the femoral pulse, posterior popliteal pulse, and posterior tibial pulse, and arteria dorsalis pedis. During examination, we should assess the rate, rhythm, volume, and character of the pulse, and also the radioradial and radiofemoral delay. This is a video clip of the pulse examination. First, start with the examination of the radial pulse. Assess the rate and rhythm of the radial pulse with the 3 fingers of the flexor surface of the hand. Then compare both the if there is any radioradial delay present or not to exclude the coarctation of aorta. Then palpate the brachial pulse. And examine the collapsing pulse to exclude the aortic regurgitation. First, hold the hand and suddenly elevated above the head. Feel the pulse. In case of collapsing pulse, sudden feel the large volume pulse, and then assess the carotid pulse to assess the volume and character of the pulse. Assess carotid pulse individually. Don't press or palpate both pulse at once because it reduces the cerebral blood flow. Radial pulse is for rate and rhythm, carotid pulse for volume and character, and brachial pulse is for record blood pressure. First, examine the radial pulse with the 3 fingers at the flexor surface of the hand. First finger is used for fixation, second finger is for palpation, and third finger is for block the collaterals. And if you feel the rhythm, if the rhythm is regular, count the pulse 50 seconds, but if feels the irregular, count pulse full 1 minute. Normal pulse rate is 60 to 100 per minute, less than 60 called sinus bradycardia, and more than 100 called sinus tachycardia. These are some pictures of the pulse. This is the position of the carotid artery, and this is the examination method of the carotid pulse. This is the position of the brachial artery, and this is the examination method of the brachial pulse. And
one second, Jannat, 1 second. Can you tell them the anatomical point of these pulses? So in the carotid pulse, you are saying that it is in the side of the trachea and anterior border of the sternocleidomastoid.
Yes.
Like this, you can mention them brachial artery. About the brachial artery, one important thing is that you can use your thumb, because thumb is the most sensitive finger amongst all. So you can mention them about the location, anatomical location.
A carotid pulse is present in the medial border, lateral border of the larynx and trachea, and medial border of the sternocleidomastoid muscles, just medial end of the clavicle. And this is the location of the carotid pulse, and brachial carotid artery, and brachial artery is placed in the antecubital fossa, along with the above the ulnar portion of the head of the elbow joint. Just feel against the head of the ulna. You will feel the brachial pulse. And arteria dorsalis pedis pulse present in the dorsum of the foot, in between the flexor tensor ligament of the toe, and posterior tibial arterial pulse is present the just beside the tendo-achilles muscle,
behind the medial malleolus.
Medial malleolus, just behind the medial malleolus. This is the examination method. With the 3 fingers, you palpate, should palpate the arteria dorsalis pedis, and with the 2 fingers, you should palpate the posterior tibial artery. Primitive fever, congestive heart failure, and arrhythmias are the pathological causes of tachycardia, and complete heart block and 6 sinus syndrome are the pathological causes of bradycardia. Pulse volume.
Tell them physiological cause first, because in examination we want to listen from them what are the physiological causes of the tachycardia and bradycardia. Tachycardia,
anxiety, stress, and anxiety, stress, and after tea or coffee consuming, and in case of the children, and in case of during sleep, and athletes, sinus bradycardia may occur.
Yeah, and tachycardia, one of the common causes is thyroid disorder, thyrotoxicosis.
Thyrotoxicosis. Yes.
And then hypothyroidism is a cause of
bradycardia. Is the cause of the bradycardia. Yes, madam. And the pulse volume is assessed by palpating the carotid artery. Pulse pressure gives the accurate measurement of the pulse volume. When pulse pressure lies within the 30 to 60 millimeter mercury, it's indicate the normal pulse pressure and indicate the normal pulse volume. Large volume pulse is called the bounding pulse, is found in the aortic regurgitation, patent ductus arteriosus, arteriovenous fistula, and persistent truncus arteriosus. And small volume pulse may be weak and thready and found in the congestive cardiac failure, pericardial effusion, constrictive pericarditis, and coarctation of aorta. Pulse rhythm, normal sinus rhythm is regular. Irregularly irregular found in mainly atrial tachyarrhythmias with fixed AV block, and irregularly irregular rhythm found in ventricular ectopics, atrial fibrillation, and atrial tachyarrhythmias with variable AV block. Pulse character also best assessed in the carotid arteries. Two wave. This is the percussion wave, and this is the dicrotic notch. And this is the some figure of the different type of pulse at a glance. This is the slow rising hypokinetic pulse. This is called the small volume pulse found in the cardiac failure and shock. This is the high volume pulse. This is the hyperkinetic pulse found in the high output state. And this is the collapsing pulse, which is very important for examining rapid upstroke and downstroke. It's found in the aortic regurgitation and patent ductus arteriosus, and this is the pulsus alternans. First large volume pulse, then small volume pulse is found in the left ventricular failure. And another pulse is the dicrotic pulse, the single pulse with two peak wave, which is found in the anterior dilated cardiac myopathy and also in the left ventricular failure. Before record blood pressure, you should prefer the cuff size, because the weight of the cuff is 40% should be 40% of the arm circumference, and length of the cuff should be 80 to 100% of the arm circumference. This is a video clip of blood pressure record. First, you ensure the size of the cuff is appropriate or not.
What is the normal size of the cuff in adult? For example, this one.
This cuff should be wide of the cuff should be 40% of the arm circumference, and 80 to 100% of the length of the cuff is the arm circumference.
Usually it is 12 centimeter for the adult.
Okay, madam. This is then attach the brachial, then attach the cuff with the along the brachial artery, align with the brachial artery, then inflate the cuff. Inflate the cuff until the radial pulse is palpate the radial pulse, and until the radial pulse is disappear. This is the approximate systolic blood pressure. Then deflate the cuff. Then palpate the brachial pulse and press the stethoscope over the brachial artery, and re-inflate the cuff again above the 20 to 30 millimeter above the approximate systolic pressure, and then slowly deflate the cuff 2 to 3 millimeter mercury per second, and hear the first cough sound, which is the systolic blood pressure. And when the sound disappears, this is the diastolic blood pressure. Then remove the cuff.
I just want to interrupt here.
Okay, madam.
Orthotic sound is not the systolic blood pressure. Actually, we measure this blood pressure in 3 points. So when we inflate the cuff, we raise the pressure. So there will be no sound. At first, you will go up like 200 or like these things in the manometer. At that time, there will be no sound. And then you slowly reduce what you mentioned already, that at the rate of 2 to 3 millimeter per second. And then you will suddenly hear a sound and radial pulse will appear. So this is the systolic pressure. So when first শোনা যাচ্ছে আমাকে?
ম্যাডাম মাথা মাঝখানে শোনা যাচ্ছিল না, আমি এবার আকিবকে ফোন দিতে নিয়েছিলাম। ম্যাডাম বলেন।
আচ্ছা, so when you will hear the first sound, that is the systolic pressure, and that is point A, and then
ম্যাডাম
suddenly you will hear a muffled sound. From the point of muffled sound is the point B, and that is the beginning of the korotko sound. And then after a while, the muffled sound or korotko will disappear. So that is the diastolic pressure. So
Diastolic.
korotko is not the
Okay,
first
ma'am.
one. Korotko is the last one just before disappearance of the all sound. So there are 3
Okay.
points A, B, and C, and in this way we measure blood pressure.
Okay, A for first systolic sound, then for korotko sound, and then muffled sound.
Yes.
Okay, madam. Blood pressure should record in calm and quiet room and kept rested for patient 15 minutes before recording, and avoid tea, coffee, or cigarette smoking at least 1 hour. Normal blood pressure systolic 100 to 140 millimeter mercury, diastolic is 60 to 90 millimeter mercury, and pulse pressure is the difference between the systolic and diastolic blood pressure. Normal pulse pressure 30 to 60 millimeter mercury, which indicate the normal pulse volume, and mean arterial pressure is indicate the tissue perfusion pressure, which is measured by the diastolic blood pressure plus 1/3 of the pulse pressure. This blood pressure, normal tissue perfusion pressure or mean arterial pressure is 100 millimeter of mercury. When the mean arterial pressure is normal, it is indicate the normal tissue perfusion pressure. Another terminology is the postural or orthotic hypotension. Fall systolic blood pressure more than 20 millimeter mercury after standing for 3 minutes from the lying down. And heart failure and hypovolemia is the most common cause of postural hypotension. Before going to jugular venous pressure, we will show some anatomical position of the jugular vein and carotid artery. This is the anatomical position of the external jugular vein, and this is the internal jugular vein.
Damna, can you please give me
Madam.
1 minute before going to the venous system? So,
Okay,
my
madam.
dear student, you already heard about the examination of the arterial system. So, I have mentioned that cardiovascular system has components like arterial, venous, and then the heart itself. Now, Jannat has finished the loop part, and then she has finished the arterial system. So, in the arterial system, we have examined all the pulses which can be palpable. So, we have seen radial pulse, and then brachial pulse, and then carotid pulse, even subclavian pulse you can feel over the middle part of the clavicle, and then femoral pulse, which is very important especially for the cardiologists, because we use femoral artery, then carotid artery, then subclavian, and the axillary artery for central like monitoring, for catheterization, and for many other purposes. So these arteries are very important, and after doing any procedure, we need to check the pulses, because after any intervention, any cannulation, this kind of pulse may lose, and there is chance of thrombosis, and there is chance of gangrene of the whole part distal to that portion. So this is very important. You have to know, especially those who are in cardiology, how to palpate these pulses. So Jannat has mentioned about mainly the peripheral pulse, like the radial. You know that radial is one of the very peripheral pulse, but for when there is shock, when there is hypovolemia, you will not get the radial pulse. In that time, you have to take the impression from the carotid pulse, from the femoral or other central pulses. So in the pulse system, we will see the peripheral pulse mainly for the rate, like tachycardia, bradycardia, for the rhythm, like any kind of arrhythmia. So pulse is a very big chapter. From the pulse, I can spend 1 hour with you. So in the rate, you will see many kind of diseases. What are the diseases which cause tachycardia? What are the diseases which cause bradycardia? So in this section, you will get at least 20 diseases to read, starting from the hypothyroidism, hyperthyroidism, other like pheochromocytoma. So those which are related with the like sympathetic nervous system, and like cholinergic system, these diseases can cause bradycardia and tachycardia, and this kind of drug can cause. So atropine, you know what kind of drug it is, adrenaline. So these are the all related to the brady and tachy mechanism. And then in the rhythm, you will see many kind of diseases. So there may be atrial arrhythmia like atrial fibrillation, atrial flutter, and then supraventricular tachycardia. So in this kind of thing, from the pulse, you will be able to diagnose from the ECG what is atrial flutter, fibrillation, and then supraventricular tachycardia. And one point is important. Supraventricular tachycardia is the commonest kind of arrhythmia. So all of you, more than MBBS course, like in the diploma grading, you will be asked about this. So you learn about what is the pulse rate in this kind. Like we say that it is more than 200 for the supraventricular tachycardia. So supraventricular tachycardia is a kind of arrhythmia, and you can see ventricular arrhythmia also. So these are ventricular like extrasystole, then ventricular tachycardia, ventricular fibrillation. So in this regard, you have to look at the ECGs also at the same time to know how to diagnose this condition. And you know, pulse will be like irregularly irregular. So you will be asked in which disease you will find irregularly irregular pulse. So this is atrial fibrillation. And then again, you will find some kind of heart block with this situation. So there are complete heart block where there is complete atrial and ventricular dissociation. There will be 2:1 block or 3:1 block. So in these kind of cases, you will be able to diagnose from the pulse. So pulse is not a very simple thing. It is very, very important part of examination. Even you will be able to diagnose coarctation of aorta from the asymmetry of the both radial pulse. So radio-radial delay, radio-femoral delay. And one of the very important thing is always you have to examine the pulse symmetrically. All the pulses symmetrically other than carotid pulse. So if you symmetrically examine the carotid pulse, patient may become like black for some time. For example, maybe patient will not understand anything, will go to shock-like situation because you will occlude both the carotid vessel and circulation to the brain. So other than this, all the arteries you have to examine symmetrically. And then about the volume. In the volume, you can get high volume pulse, then low volume. You know, low volume pulse is common in the aortic stenosis, hypovolemia, high volume with the hypervolemia, thyrotoxicosis. So about the in the volume part, you can see also like pulsus alternans, which is very common in left ventricular failure. One bit is high volume, one bit is low volume. So this is pulsus alternans, which is very, very common kind of pulse in left ventricular. And then pulsus paradoxus, very important in constrictive pericarditis. In case of pericardial effusion, you will see that the blood pressure is low with the inspiration. This is actually a normal phenomenon, but there is exaggeration in this situation. So this we say this pulsus paradoxus, and you will be asked give some example of the disease. For example, cardiac tamponade for the pericardial effusion. And then about the pulse wave, Jannat has shown you many ways, but for us, very important one is the collapsing pulse. Because in children, we find collapsing pulse in many situations like patent ductus arteriosus, aortic regurgitation, and then like catacrotic pulse, we find in the anacrotic pulse in aortic stenosis. Because in aortic stenosis, you know that the aortic valve is closed, so ventricle has to take extra effort to do his systole. So in that case, we found two positive wave, and that is anacrotic pulse. And after that, she came to blood pressure. In the blood pressure part, you have to know how to measure systolic and diastolic blood pressure, and then mean pressure, then pulse pressure. Pulse pressure is very important. It is the difference between the systolic and the diastolic pressure. And then if the pulse pressure widen, that is very common in case of aortic regurgitation, in case of patent ductus arteriosus. So you have to know why there is difference, because systolic is very high pressure or normal pressure, but there is diastolic runoff. Blood escapes from the circulation in case of PDA into the pulmonary artery, in aortic regurgitation into the ventricle. So in these cases, there is runoff, and diastole receive a very little amount of blood. That's why there is diastolic runoff and there is wide pulse pressure. So this is one kind of important thing. And about one of the great artery, aorta, you have to know, because in aorta there are some diseases like coarctation, dissection, and aneurysm. So you have to know about these. In some of children, we see that there is aortic aneurysm, and in those cases, you will get some of the findings of aortic aneurysm or dissection. In dissection, there is a false channel inside the aortic wall, and then the main lumen of the aorta occludes. So this patient has a history of chest pain, acute stabbing pain, and then they go to collapse because there is no circulation in the distal part of the aneurysm, distal part of the dissection. In the aneurysm, there will be fusiform swelling, and then there will be pressure effect on the surrounding structure, like in the trachea or in the bronchus. So what will happen? There will be respiratory distress, maybe pressure in the recurrent laryngeal nerve, so there will be hoarseness of voice. So you have to consider all these hundreds of things from the pulse. Pulse and blood pressure are not so easy. And if we want to ask any question, then patient will not be able to answer these things. We know. So these are very simple things, but you never read. You feel that these are very easy. But these are not very easy. And if we ask any question from these chapters, I am sure that most of the students will not be able to answer. So please read these things to be a good doctor. Okay, Jannat, you can proceed with the venous system now.
Okay, madam, Dr. Ashik raised his hand. So Ashik, you may ask. Dr.
Yes,
Ashik.
Assalamu alaikum, madam. Assalamu alaikum, madam. Should we examine pulse? Collapsing pulse is a regular part of the examination during pulse examination.
Collapsing pulse, how you examine? Okay, Jannat, just tell them how to examine.
Should we examine this as a regular part of pulse examination?
Yes, just you examine the radial pulse, then symmetry, radial or radiofemoral, then you examine the brachial pulse and collapsing pulse and carotid pulse.
Thank you, madam.
Okay. This is the anatomical location of the neck veins. This is the pathway of the external jugular vein. External jugular vein is not used because it is valved. Internal jugular vein is used for record jugular venous pulse. The internal jugular vein is the direct continuation of the superior vena cava and right atrium, and it is not valved. And internal jugular vein are closely related with the common carotid artery. So you may confused with the common carotid pulse and venous pulse. So venous pulse has two waves, but it is rarely palpable. But carotid pulse is easily palpable. And carotid venous pulse is changed with posture and descend with inspiration, but carotid pulse is unchanged. Jugular venous pressure is the indicator of right atrial pressure expressed at vertical height from the sternal angle to the zone of transition of distended and collapsed jugular venous pressure. Right atrial pressure is the vertical height of blood column plus 5 centimeter of water. Normal jugular venous pressure is less than 8 centimeter of water or less than 4 to 6 millimeter of mercury. This is the pathway of the internal jugular vein, and this is the external jugular vein not used. And this is the external end of the sternocleidomastoid muscle. The internal jugular vein just below the sternocleidomastoid muscle and closely related with the common carotid artery. So there is a difference between the jugular venous pulse, rarely palpable, but it is visual pulsation, and it is the palpable and vigorous thrusting pulsation, and it changes with posture and position and inspiration, but it is unchanged. This is a picture of record jugular venous pressure. Make the patient comfortable and lying on back with the head 45-degree angle, and place a centimeter ruler at the external angle that is called angle of Lewis. A centimeter ruler placed vertically and a card placed horizontally at the upper point of height of the pulsation. Then make a right angle. And this is the vertical measurement is the measurement of the jugular venous pressure is recorded in centimeter of water or in millimeter of mercury. This is a video clip of jugular venous pressure record. Right internal jugular vein. This is the right internal jugular vein. This is the external jugular vein. The external jugular vein is not used because it is valve. This is the middle of one clavicle, sternocleidomastoid muscle. Right internal jugular vein is used because it is the direct continuation of superior vena cava and right atrium and directly above the right atrium.
What is the applied anatomy of this internal jugular vein? You can mention them. Or the application, clinical application of this internal jugular vein.
When we do catheterization, we use the internal jugular vein.
No, this is main importance is to measure central venous pressure. So whenever a patient is in ICU, is critically ill, they need central venous pressure measurement for fluid assessment or for other things. So you need a central venous line, and this is the most common site of central venous pressure measurement.
Central venous pressure, yes. So then lie the patient is supine position with the 45-degree angles and turn the head left lateral position, and visualize jugular venous pulse. This is the a wave with 2 pulses per heartbeat, but in case of carotid pulsation, 1 pulse per heartbeat. This is the distinguished point between the carotid pulse and venous pulse. ম্যাডাম এটা একটু স্লোই রাখছিলাম যে ওরা একটু বোঝার জন্য, জেভিপিটা একটু কঠিন তো আমরাও এমবিবিএস স্টুডেন্টরা বোঝার জন্য।
Okay, after your discussion I will tell you in a simple way how to understand this JVP. So please finish your part and go to the wave diagram. I will tell them from the wave diagram.
Okay. So distinguish from carotid artery, 2 pulse per heartbeat in case of jugular venous pulse and no palpable pulsation. But carotid pulse is palpable and thrusting in nature. If you confuse is it a jugular venous pulse or carotid pulse, then press over the lever and causes the temporary increase the raised jugular venous pulse. This is called the hepatojugular reflex. Then measure the height of the this is the external, measure the height of the jugular venous pulse. This is the external angle called the angle of Lewis. Place the centimeter ruler at the point of the angle of the sternum. And see the visible pulsation in the neck, and a card placed in the height of the pulsation, and make the right angle and measure the vertical height from the external angle. This is the measurement of the jugular venous pressure. Height of JVP. Normally less than 4 to 6 millimeter of mercury or less than 8 centimeter of water. Jugular venous pressure have his own wave. This is the C wave. A wave, C wave, V wave, and two descent, X descent and Y descent. A wave is formed due to the atrial contraction, a backward pressure created in the internal jugular vein and causes the A wave. And after A wave, the atrial relaxation occurs, where blood passes through the tricuspid valve and to the right ventricle and causes the X descent first part. And then when the after valve closure, the tricuspid valve bulges towards the right atria and causes the another backward pressure in the internal jugular vein, causes the C wave, and then causes the second part of the X descents. And after the relaxation of the during the relaxation of the ventricular contraction, after the ventricular contraction during the relaxation part, and then again the V wave produced due to the atrial filling from the superior vena cava. V wave is appeared the V wave, and after atrial filling, open the tricuspid valve and blood passes towards the right ventricle and causes the Y descent. So internal venous jugular venous pulse has 3 wave and 2 descents. Congestive cardiac failure, fluid overload, constrictive pericarditis, and cardiac tamponade are the most important cause of elevated JVP, and hypovolemia and shock are the most common cause of the decreased JVP. Sometimes in some diseases there is no A wave is found. In case of atrial fibrillation, A wave is not produced because atria cannot contract properly, and giant A wave formed with each beat. A giant wave is formed in case of the right ventricular hypertrophy and tricuspid stenosis, also in pulmonary hypertension. And this is the cannon wave JVP. This is the intermittent and various height of the A wave. This is the cannon wave JVP. It is found in the complete heart block, common in complete heart block.
Just a minute. This is cannon wave. Cannon
wave. Cannon wave.
This
found in complete.
This occurs when atrium contract against a closed tricuspid valve. Right atrium contract against a closed tricuspid valve. Sometime in case of AB block.
Yes, madam. Complete AB block. এটা পরীক্ষায় প্রায় ধরা হয় যে কেন নয় পাওয়া যায় কিসে বা কমপ্লিট হার্ট ব্লক কিসে কি ওয়েভ পাওয়া যায়. This is the another sign is the Kussmaul signs. They are found in the right ventricular failure, constrictive pericarditis, and cardiac tamponade. And Friedreich's sign found in the constrictive pericarditis. This is the video clip of Kussmaul signs. Kussmaul signs normally during inspiration, jugular venous pulse is descends due to negative intrathoracic pressure. Blood is sucking. But in case of the few condition, paradoxical raised jugular venous pressure pulsation, which is called the Kussmaul signs.
একটু বাংলায় বুঝিয়ে বলো ওদেরকে Kussmaul সাইনটা।
ম্যাডাম নরমালি হচ্ছে ইন্সপিরেশনের সময় জুগুলার ভেনাস পালসটা একটু নিচের দিকে নেমে যায়, আর কারণ হচ্ছে থোরাক্সের নেগেটিভ ইন্টারথোরাসিক প্রেসারের জন্য ওই সময় তো ব্লাড গুলি সাক করে হচ্ছে সুপ্রিয় ভেনা কাভা থেকে রাইট এট্রিয়ামে ব্লাড আসে, সব জায়গা থেকে ব্লাডটা হয়, তখন এই জন্য প্রেসারটা ফল করে। কিন্তু এই ইসের Kussmaul সাইন যেটা এই মোস্টলি কমনলি 3টা কন্ডিশনে হার্ট ফেলিওর, কনস্ট্রিক্টিভ পেরিকার্ডিটিস এবং কার্ডিয়াক টেম্পোনেট এইসব কন্ডিশনে দেখা যায় যে প্যারাডক্সিক্যালি মানে যখন নামার কথা তখন পালসটা নামে না, কিন্তু দেখা যায় আরো রেজ করে পাওয়া যায় ইন্সপিরেশন সময়, আর জুগুলার ভেনাস পালসটা আরো হয়, হাইট অফ দ্য পালসেশন বেশি পাওয়া যায়। আর ফ্রাইড্রিচ সাইনটা হচ্ছে র্যাপিড, এটা হচ্ছে Kussmaul সাইন্স। And this is the Friedreich's sign. This is the this occur in the constrictive pericarditis. This is the sharp, rapid rise and rapid fall of the jugular venous pulse. This is the Friedreich's sign found in the constrictive pericarditis. If you, madam, to say something.
Yeah, about the
regarding
venous,
this examination.
About the venous, you can go to your wave, the S, T, V, and XY.
Okay, madam. Slide.
Yes, side of the venous wave. So So she already has mentioned that there are 3 positive waves and 2 negative waves. So we learned this in our MBBS, and I was in MBBS in 1985. So since then, now how long we are actually remembering these things, and we never forgot the Hutchison. So for the undergraduate, I will request you to read Hutchison properly, and you will never forget this thing in your cardiovascular system is very important for any specialist. Even if you are a nephrologist, you need to know. Even if you are a neurologist, you need to know. So whatever will be your future plan, you need to know the examination of the cardiovascular system. And for the postgraduate student, the easy book is McLeod's Clinical Examination. So the undergraduate, I will request, and for the postgraduate, Hutchison is good, but Hutchison is very good for the undergraduate, and McLeod's Clinical Examination is very good for the postgraduate student. So now the wave is in front of you. You are seeing that there are C and B 3 positive wave. So this is a venous wave taken from the right internal jugular vein. This jugular vein, what is its significance? This vein is directly connected with the right atrium. So whatever is going on in this wave, this is the reflection of the right atrial pressure. So during the systole of the right atrium, pressure will be increased inside the right atrium, and during the diastole of the right atrium, pressure will be decreased. Somebody's mic is on. Can you mute yourself? So main simple thing is atrial contraction or atrial systole and atrial diastole. So in the first wave, in A, it is the atrial systole. And the first descent, X descent, it is the atrial diastole. So just remember this easy thing from this complex wave that A, the first positive wave is the atrial systole or atrial contraction. And the first negative, X descent, it is the atrial diastole. But during the atrial systole and atrial diastole, something is going on inside the ventricle also. So other things are the actually reflection of the ventricular activities, because you know the ventricle is a very strong chamber and atrium is a poor chamber with very little pressure. Maximum pressure inside the right atrium is 5 millimeter of mercury. And when a patient lies in supine position, you will never see the jugular vein, because it can go up to 7 millimeter only above the right atrium. And this internal jugular vein has 2 parts. One part is distended, which is directly attached to the atrium, and it is only 7 millimeter. And the next part is collar. আচ্ছা কে কথা বলছে প্লিজ করে দিয়ে গেছিল ক্যান ইউ প্লিজ মিউট হু ইজ টকিং চেয়ারম্যান ছিল না না উনি ডিরেক্টর ছিল those who are talking please mute. So A wave is the atrial contraction, and anything which increase the atrial contraction or which reduce the atrial contraction will reflect in this wave. And then why there is again C in the descent part? Now that in the diastole part the pressure is decreasing inside the atrium, but why there is again a positive peak? This positive peak is because of transmission of the carotid artery. You know that jugular vein is very close to the carotid artery. So during atrial diastole, carotid artery is doing its systole. What happened? The carotid systole transmit it to the venous side as they are very close. So there is a transmitting positive wave, and somebody says that it is because of as the tricuspid valve is during the ventricular systole, tricuspid valve sometimes push backward. So this may be due to the pushing backward of the tricuspid valve. So this is the C wave. So A, for sure it is atrial systole. C, it is the ventricular systole reflecting from the carotid pulse or from segment of the tricuspid valve. Then now why there is B? B is again a positive wave, and for the easy remembrance, you can say that it is prior to the opening of the tricuspid valve, this V happen. So before opening of the tricuspid valve, atrium is filled with all venous return from the superior vena cava and inferior vena cava. So atrium is now in diastole, and lot of blood is rushing inside the right atrium from the superior and inferior vena cava. So this V is those rushed blood, those accumulated blood inside the right atrium just before opening of the tricuspid valve. So just before opening of the tricuspid valve and just before starting of the atrial systole, the blood itself creates some positive pressure without any contraction. So this A is due to contraction and B is because you can simply understand that this is because of the volume, because of superior and inferior volume inside the atrium, there is some spike. Again, there is a spike. And then Y descent, what happened in Y descent? This is the commencement of the ventricular diastole. So in this time, blood rushed inside the ventricle. So you know the first one-third part of the ventricular diastole, there is simply blood flows easily from the atrium to the ventricle without any atrial contraction. So in Y descent, atria still not yet contract, but blood is passively going into the ventricle. Otherwise, A should overlap with the Y, and you will not see any A, any Y. So A is not overlapping with the Y, though there is ventricular filling, and this is the atrial systole now. Y is the atrial systole, but atria has not yet started contraction because first one-third part of the blood filled by itself, passively. So now I think you understand A is atrial contraction, C is the transmission of the carotid pulse, X is the atrial diastole, B is venous return and the distended atrium, which creates some pressure in the wave just before opening of the tricuspid valve, and Y is the opening of the tricuspid valve and filling of the ventricle, passive first filling part of the ventricle. So I think you have understand now. And not only the jugular venous pulse, you have to know also about the peripheral veins like the peripheral arteries. So you have to know whether there is any varicose vein, whether there is any venous thrombosis, which may happen whether there is any thrombophlebitis. So in peripheral vein diseases can happen. One is thrombophlebitis, which may be due to arterial venous cannulation or from insect bite or from like sometimes it is spontaneous and sometimes because of the malignancy. And then the venous thrombosis may be due to abdominal tumor or some of the cancer or from sitting or a post-operative or sedentary work, less movement. These are the cause of venous thrombosis, and venous thrombosis is actually a very common cause of a dangerous disease, pulmonary embolism. So we should protect ourselves from venous embolism, venous thrombosis. Another thing is varicose vein. We know that there are many venous valves which direct the venous blood to the right atrium against the gravity. Sometimes these valves become like inactive or they lost their function. So in those cases, there may be varicose vein. So during examination, you should see whether there is thrombophlebitis, varicose vein, etc. So this is also a part of cardiovascular examination. Thank you, Jannat. You can proceed now.
Madam. So the examination of the heart is examination of the precordium is performed with the patient lying in the supine position, and it begins with the general examination, which gives a very important message like the shape of the chest, any bony abnormalities, any visible pulsation, any scar marks or dilated veins. This is a video clip of the examination of the precordium, step by step. First assess the do the general inspection, then palpate the apex beat. First palpate the palmar surface, then localize with a finger and count from the sternal angle the space of apex beat. it is a 5th or 4th intercostal space. Then palpate the any chill, all the four side, and then auscultation is the key technique to assess the heart rhythms and any abnormalities of the heart disease. First, it diagnoses the systolic or diastolic in the apex left hip intercostal space, then left fourth intercostal space, and then right second, and then right left intercostal space, and also then carotid arteries. Then identify any added sound is there. Is there any added sound? Is it systolic or diastolic? All four areas, site, radiation, and timing of the added sound, and also character of the added sound. Then examine for mitral. Is there any added sound for mitral regurgitation? In the place the stethoscope in the apex and see the radiation in the axilla after full expiration. And in case of mitral stenosis, auscult with the welt of the stethoscope in left lateral position after full expiration. And see the any radiation present in the aortic stenosis. In aortic stenosis, murmur radiates to the carotid arteries. And then leaning forward position, auscult the aortic space to see the aortic regurgitation murmur. Is there any aortic regurgitation murmur present or not? This the normal chest shape is the bilateral symmetrical, and transverse diameter is more than anteroposterior diameter 2:1. And see the any abnormalities in the chest shape like the pectus carinatum or pectus carinatum. This is the pigeon shaped chest, and this is the pectus excavatum. This is the it is the scar mark in the central of the chest, and this is a midline scar mark. And this is a scar mark, right thoracotomy scar, left thoracotomy scar, and midline thoracotomy scar for cardiovascular surgery. And have a look to see the visible pulsation in the carotid area for hyperdynamic state, and suprasternal area for coarctation of aorta, and epigastric area for heart failure or right ventricular hypertrophy. And also see the back for any pulsation seen in the coarctation of aorta. During palpation, the general fingertip is used for localize the pulsation, and base of the fingers are used for chill, and the base of the hand is used for palpate the hip. First we palpate the apex beat, then we palpate for any chill in the four valvular area, and then in the right left intercostal space for hips for right ventricular hypertrophy. This is the examination method. First feel the apex with the palmar surface of the fingers, then localize the apex beat and count the apex beat. If it is not palpable, then turn the patient to left lateral position and identify the apical impulse or apex beat. In case of infant, it is found in the left foot intercostal space lateral to mid clavicular line, and up to 5 years it's found in the mid clavicular line, and in older children left fifth intercostal space just medial to mid clavicular line. Then assess the apex beat. Is it normal or tapping or diffuse or heaving? In mitral stenosis, apex beat should tapping, and volume overload, ventricular dilatation and volume overload, diffuse apex beat can found, and in ventricular failure and pressure overload, heaving apex beat can found. Parasternal heave is the palpable thrust which leave the palpating hands. You've seen in the right ventricular hypertrophy or left atrial enlargement, and these are also the palpable vibration of murmurs above the grade 3 murmur. This is the auscultation. Auscultation techniques. Auscultation is the key techniques to assess the cardiac heart sound and added sound. Auscult of all the four individuals area, like this is the apex, left fifth intercostal space. This is the mitral area. This is the tricuspid area, left fourth intercostal space, just lateral to sternum. This is the pulmonary area. This is the left second intercostal space, and this is the right intercostal space, right second intercostal space. This is the aortic area. So first heart sound is best heard in the mitral area or apex, and second heart sound is best heard in the base of the heart, the mitral and pulmonic and pulmonic and aortic area. First heart sound is produced due to the closure of the AV valve, mitral and tricuspid valve, and second heart sound is produced due to the closure of the pulmonary semilunar valve, pulmonary or aortic valve. This is another point. This is called the Arps point. This is the left third intercostal space. Some maximum times, the most of the normal heart sound and pathological heart sound can hear in this point. This is the video clip of the of the heart sound. Labda.
The first heart sound, low, also known as S1, is caused by the closing of the AV valves after the atrium have pumped blood into the ventricles. The second heart sound, dub, or S2, originates from the closing of the aortic and pulmonary valves right after the ventricles have ejected the blood. The time interval between S1 and S2 is when the ventricles contract, called systole. The interval between S2 and the next S1 is when the ventricles relax and are filled with blood, called diastole. Diastole is longer than systole, hence the lubda, lubda, lubda. Heart sounds are auscultated at 4 different sites on the chest wall, which correspond to the location of blood flow that passes through the aortic, pulmonic, tricuspid, and mitral valves, respectively. This is how similar defects associated with different valves are differentiated.
So I think you will never forget this first and second heart sound, lubda. So this is the first heart sound due to the closure of the atrioventricular valve, and this is the closure of the semilunar valve. Maximum point is the apex beat or mitral area, and this is the second heart sound. It is commonly found in the base of the heart. This is the pulmonic and aortic area. Some pathological condition is the loud first heart sound. We will get in the high cardiac output state, and split first heart sound may be found in the pulmonary hypertension. And second heart sound has physiological splitting, but in case of wide and fixed splitting found in the atrial septal defect, and wide variable splitting found in the ventricular septal defect, but narrow split found in the severe aortic stenosis and severe pulmonary stenosis. So this is very important, ASD and PS, and in case of AS, narrow splits and wide and fixed split. This is the second heart sound. Third heart sound may be physiological, may be pathological. In case of children and young adults, physiological third heart sound you will get, and in case of the high output state or ventricular septal defect, ASD and PDA, in case of congenital heart disease, pathological third heart sound may get. And third heart sound is called the ventricular gallop, and fourth heart sound is called the atrial gallop. Third heart sound sometimes may due to the some physiological condition, but fourth heart sound always pathological. It's due to it is found in the late diastole, and third heart sound found in the early diastole. And this can found in the systolic due to the systolic congestive heart failure. And fourth heart sound always found in diastolic congestive heart failure. And there is an added sound which is called the murmur, due to the turbulence of blood flow, due to the increased blood flow through the normal valve or normal blood flow through the stenosis valve. Sites of the murmur is the precordium, back, and carotid region. This is another
based on the time they occur in the cardiac cycle, their changes in intensity over time, the auscultation site where they are best heard. Examples of conditions associated with common systolic wounds include mitral valve regurgitation, when the mitral valve does not close properly and blood surges back to the left atrium during systole. The murmur starts at S1, but the AV valves close and maintains the same intensity for the entire duration of systole. This hollow systolic murmur is
best towards the mitral region, the apex, with radiation to the left axilla. On the other side of the heart, a tricuspid valve regurgitation has similar timing and shape, but is loudest in the tricuspid area and slow radiates up the left sternal border. Aortic valve stenosis. When the aortic valve does not open properly and blood is forced through a narrow
শোনা যাচ্ছে না জান্নাত, you can skip this.
ম্যাডাম শোনা যাচ্ছে না?
না, এটা স্কিপ করে দাও, এটা যারা ওরা এই ভিডিওটা ওরা পাবে নেটে, ওটা দেখতে পারবে।
আচ্ছা ম্যাডাম, আমি তো শুনতে পারতেছিলাম। This is the phonographic picture of the early systolic murmur, just heard just after the first heart sound in case of VSD and severe tricuspid regurgitation and mitral regurgitation. Early systolic murmur found. This is the late systolic murmur. Start a short period after the first heart sound in mitral and tricuspid valve prolapse. Systolic murmur, late systolic murmur can found, and this is the continuous murmur which is start first after just immediate the first heart sound and continue through the systole and whole period of the diastole. This is found in the patent ductus arteriosus. And early diastolic, this is the diastolic phonographic picture of diastolic murmur. Just start immediately after the starting of diastole, and this is the mid diastolic murmur. This found short after the start of diastole. This found in the mitral stenosis and tricuspid stenosis. This is the ejection systolic murmur, which is start immediate after the first heart sound and continue till the second heart sound. And pansystolic murmur start first heart sound and continues through the whole the systole up to the second heart sound. The grading of the murmur: first stage 1 is very soft, stage 2 is very soft but easily audible, and stage 3 is moderately audible but no thrill, and stage 4 with always thrill, and stage 5 murmur is very loud, and stage 6 stage is the loud and audible without stethoscope. And there are some murmur. This is the Keratin murmur, Graham-Still murmur. The Keratin murmur is found in the rheumatoid heart disease, and the Graham-Still murmur found in the aortic regurgitation. It is found in the apex, and it is the left based heart of the left sternal border, left second intercostal space. And Gibson's murmur is a machinery murmur, continuous machinery murmur of PDA. And Cholichil murmur is the aortic found in the aortic regurgitation, heard in the axilla. And Austenfeld murmur is the mid diastolic murmur, which is heard best heard at the apex in severe aortic regurgitation. And innocent murmur is another terminology, which is functional benign, accentuated during the febrile illness or high output state. Patient may be always asymptomatic without cyanosis, with normal pulse and heart sound, always below the grade 3, and always the usually systolic murmur with normal chest X-ray. And another added sound is the opening snap due to the opening of the AV valves. Normally, AV valves do not produce any sound, but in case of some pathological condition, in case of VSD and PDA, may produce a sound which is called the opening snap, and this may be heard in the also parasternal region in case of tricuspid stenosis and regurgitation, and also sometimes in atrial septal defect. And this is the ejection click is another pathological sound which arises from the cardiac burst due to the sudden swelling of the pulmonary artery or abrupt dilatation of the aorta. And in early ejection systolic click also seen in the aortic and pulmonary stenosis. Pericardial rub, this is due to the sliding of the two inflamed layer of the pericardium. This is the scratching and grating in character, and this best heard in the sternal third and fourth intercostal space. Now I humbly request Madam to put her valuable opinion regarding these few slides.
So I think you have finished already, or you have more slide?
No, Madam, I have only 3 slides.
Okay, so this part I think students are aware of this, and they always examine precordium properly. And okay, I have seen that they are actually more concerned about the precordium rather than the other part which we have discussed already, like general inspection and then like venous system, arterial system. So in this part, I don't want to add anything. They are doing right things. Here they are in right track, but only thing is that during auscultation, they have to be careful that they should not auscultate only the precordium. They have to auscultate the carotid area and the back. And also the expiratory murmur for the left side of the heart, like sitting and then leaning forward and breath holding expiration. So these are from my part. You can continue.
Okay, madam. First, when we see the peripheral signs of the cardiovascular system, if you see any dysmorphic feature, you should search at the another feature of the dysmorphism, because this is the feature of Down syndrome. Down syndrome is commonly associated with the AV canal defect and ventricular septal defect. This is the feature Edwards syndrome, commonly associated with the VSD, SD, and PDA. This is the Patel syndrome, is the commonly associated with the VSD, PDA, and PS, and this is the whole arm syndrome. This is the commonly associated with primum SD, atrial septal defect, and this is the feature of the Marfan syndrome, commonly associated with the mitral valve prolapse and mitral valve diseases, and this is the Turner syndrome feature. Patient commonly associated with the coarctation of Turner syndrome is commonly associated with Turner syndrome is a coarctation of aorta, and this is the feature of the Noonan syndrome. This is the feature of the Noonan syndrome. So you must search the Down syndrome, which is commonly associated with the AV canal defect and VSD, and Edwards syndrome, commonly associated with the ventricular septal defect, PDA and PS. Patel syndrome is associated with VSD, PDA, and dextrocardia. Noonan syndrome is PS, peripheral pulmonary stenosis, commonly association, and common association, and Marfan syndrome is commonly associated with the mitral valve prolapse, aortic regurgitation, and Turner syndrome is commonly associated with AS and coarctation of aorta, and Holm-Arp syndrome is commonly associated with ostium primum, ostial septal defect. And this is my last slide. This is some anatomical marker, which commonly used to describe different anatomical location. This is the mid axillary line, which a line passes through the running vertically downwards to the surface of the body, passes through the apex of the axilla. This is the anterior axillary line, which is the parallel line of the mid axillary line, which passes through the anterior axillary fold. This is the posterior axillary line, passes through the posterior axillary fold, and this is the supraesternal notch, and this is the sternal angle. This is called the mediusternal joint. Another name is angle of Lewis. This lies within the thoracic third and fourth vertebra, corresponds with the second intercostal space. And this is the mid clavicular line. A vertical line passes downwards, running downwards to the surface of the body and passes through the midpoint of the clavicle. This is all my cardiovascular system examination. Thanks everybody for patient sharing.
Thank you, Jannat. I think this was a very fantastic presentation, and you have worked hard to prepare this lecture for the student. I don't know how much they were attentive or how much they have learned, but your initiative was really a wonderful one. And those who have not attended, they have missed a very wonderful session, because it is not possible to arrange time for such discussion. It was almost 2 hours now. So I would be very happy, those who are in the class, if they can perform good in their exam, even if not the best. Even if they perform ordinarily, I will be very happy. So with this, I would like to express my thanks to Beximco for helping us in this lecture class from the digital side, and also all the students who have attended this class, and also my assistant Rakib for sending all the message and taking pain to help Jannat and me to organize this class. So I think we can stop here now, because it's already 2 hours, and we will see you again in future in any other class. Thank you so much.
Thank you, madam. We will enjoy the class and learn a lot from you, madam. Thank you for such nice class, madam. Thank you, madam.
Thank you.